Alright, this is going to be Critical Care Pharmacology Part 3, Antidysrhythmics. Antidysrhythmics is something that we use to kind of maintain normal cardiac conduction and the pathways to maximize cardiac output. Many drugs in this category lengthen the relative refractory periods that kind of retard what the heart's trying to do. Automaticity disturbances and reentry mechanisms would be two examples of these. First drug on our list is going to be Lidocaine, or Xylocaine. Classification is an antiarrhythmic, class 1B, which happens to be all class 1s, would be sodium channel blockers. And this will refer to the sodium-potassium pump on the surface of the cell. It's a CNS agent and a local anesthetic. Action on this is suppresses ectopic ventricular foci, raises ventricular fibrillation threshold, blunts intracranial pressure in rapid sequence intubation. Efficacy as far as an antiarrhythmic got questioned the last time with the last American Heart Association update. Exhibits local anesthetic properties. Indications: ventricular ectopy and dysrhythmias. Contraindication: any known hypersensitivity. Stokes-Adams syndrome is pretty much constellation of symptoms due to complete heart block. So we would never give an antidysrhythmic to somebody in complete heart block unless they form something constructive. And what I mean by that is they went into VTAC, or they had a run of VTAC, or they had sustained VTAC, which we needed to convert. Ventricular ectopy in the presence of bradycardia, and where we have ectopic beats in the presence of bradycardia, we're always going to treat rate over rhythm. There's a good chance, if we have an underlying rhythm that's bradycardic, that if we increase the speed of it, that we will actually solve the problem of the heart trying to find another pacemaker site, or the ectopy. Side effects: anxiety, seizures, hypotension, bradycardia, cardiac dysrhythmias, nausea, vomiting, drowsiness, paresthesia. Dose for the adult: 1 to 1.5 milligrams per kilogram. Repeat every 5 to 15 minutes for a maximum dose of 3 milligrams per kilogram. Maintenance dose is 1 to 4 milligrams per minute. Whenever we see things that are in milligrams per minute, how we figure that is going to be dose times drip factor divided by concentration strength. Standard concentration strength of lidocaine is going to be 4 milligrams per milliliter. Let's say we wanted to go make it run at 2 milligrams per minute. 2 times 60 is 120 divided by 4, which equals 30. That would be 30 mils an hour, or 30 drops per minute. Pediatric dose: 0.5 to 1 milligrams per kilogram with a maintenance infusion of 20 to 50 mics per kilogram per minute. Now, whenever we figure these, dose times weight in kilograms times drip factor divided by the concentration strength. Now, remember the concentration strength. This is in mics. Your normal lidocaine drips in 4 milligrams per milliliter. So how many mics are in 4 milligrams? And the answer is 4,000. So dose on this, if we wanted it to run at 20 times the weight in kilograms of a child, let's say he's a 20 pounder or 10 kilogram, times 60 divided by 4,000 is how we would set that up on the calculator. Special considerations: use cautiously in patients with renal and hepatic failure. It is formed, the active metabolites form through metabolization in the liver, and lidocaine toxicity. Procainamide hydrochloride, or Pronestal. Classification: cardiovascular agent. Antiarrhythmic class is 1A, which is also a sodium channel blocker. Action: suppress conduction velocity through the conduction system, and this is in the atria, the AV node, or the Purkinje system. Prolongs atrial refractory period and exerts negative inotropic and negative chronotropic effects. So it kind of slows things down as well for us. Indication: ventricular dysrhythmias. Contraindications: known drug allergy, myasthenia gravis. It does have an increase in parasympathetic tone, just a little bit. Um, blood dyscracies, which means pretty much blood disorder of any type, high white count, polycythemia with the red blood cells, and so on. AV conduction blocks, torsades de pointes, asymptomatic premature ventricular contractions, just PVCs that have no symptom with it, dig toxicity, and hypotension. Now, if you want to think about these things right here, let's see, AV conduction blocks, torsades, and dig toxicity, all of those are going to increase your QRS width. One of the secondary causes of torsades de pointes, besides low magnesium levels, is an increased QRS width. The heart feels that it needs to find another pacemaker site, so it finds many pacemaker sites. Another word for torsades is polymorphic BTAC. Dig toxicity will widen things out, and then we'll find alternate pacemaker sites as well. Side effects, hypotension and conduction defects. Dose on this is going to be 20 milligrams per minute loading dose. Infuse until one of four things occurs. Maximum dose of 17 milligrams per kilogram is reached. The ectopy ends, hypotension develops, or QRS or QT lengthens, and the lengthens greater than 50%. So if you run an initial 12 lead and the first 12 lead, your QRS duration is 0.08 seconds or 80 milliseconds. And your second QRS duration is 0.16. Is that more than 50%? The answer is yes, it is, or 160 milliseconds. Maintenance infusion of 1 to 4 milligrams per minute, and we should titrate to effect on this. Special considerations, monitoring blood pressure and cardiac rhythm very closely. Amiodarone hydrochloride, classification, cardiovascular agent and an antiarrhythmic class of class 3. Class 3 is a potassium channel blocker. Actions, blocks sodium and potassium channels both, but it holds the classification of a potassium channel blocker. Increased duration of action potentials, refractory period, vascular smooth muscle relaxation. Now, in the big scheme of things, this thing hits every ability that your heart has to beat. It also may cause hypotension in the conscious patient. Decreases peripheral vascular resistance and afterload. That's because it has a calcium channel blocker in it as well. It's a multi-use antidysrhythmic. Indication, ventricular dysrhythmia, atrial dysrhythmia refractory to other treatments. Contraindications, known hypersensitivity to the drug, any kind of sinus bradycardia, any kind of high degree heart block, second or third degree heart block, cardiogenic shock, and severe congestive heart failure. Side effects, hypotension, bradycardia, AV blocks, ventricular dysrhythmias, pulmonary toxicity is a possibility with administration of amiodarone, anorexia, and nausea and vomiting. Dose on the adult, if they have a perfusing ventricular dysrhythmia, 150 milligram bolus over 10 minutes, and that's about 15 milligrams per minute. Easiest way to deliver this is to probably put it into a syringe pump and deliver it, put the 150 milligrams into 10 mils and then deliver that 10 mils at a mil a minute or 60 mils an hour. Maintenance drip on this after we get through running it in is 1 milligram per minute, infused over the first 6 hours, and then after that 0.5 milligrams per minute over the next 18. Non-perfusing ventricular dysrhythmias, 300 milligram IV bolus, and you may repeat this once at 150 milligrams in about 5 to 15 minutes, depending on the amplitude of your ventricular ectopy. Pediatrics, 5 milligrams per kilogram IV IO or rapid IV bolus. Maximum dose of 15 milligrams per kilogram can be given in the kiddo. Special considerations, correct any kind of form of hypokalemia or hypomagnesemia before administration, and please protect it from light. Atropine sulfate, classification, sympathomimetic, parasympatholytic, anti-muscarinic agent. Actions: blocks acetylcholine receptors, resulting in tachycardia and smooth muscle dilation. Used to reduce oral secretions before a rapid sequence intubation. Indications: increased parasympathetic tone, where they'll vagal themselves out. Now remember, whenever we intubate individuals, we can actually increase parasympathetic tone by the introduction of the laryngoscope. Rapid sequence intubation. Contraindication: known hypersensitivity to belladonna alkaloids. Side effects: palpitation, tachycardia, dry mouth, dilated pupils, and anxiety. Dose: cardiac dosing is going to be 0.5 to 1 milligram IV push every 3 to 5 minutes. We can also use this for sinus bradycardias. Maximum dose of 3 milligrams. In organophosphate poisoning, 2 to 3 milligrams IV push, and there's no max dose on this. Repeat as needed. In the pediatric patient, 0.01 to 0.03 milligrams per kilogram IV push. Special considerations: monitor blood pressure and cardiac rhythms closely. Additive effect with other anticholinergic agents. Adenosine or adenocard. Classification: cardiovascular agent, arrhythmic class of a class 1A. Endogenous nucleoside occurring in all the cells, slows conduction through the AV node and reentry pathways. Indications that we're going to use this for is SVT. Contraindications: if they have any kind of AV block or they have sick sinus syndrome. Side effects: we can actually give them a heart block, put them into VTAC or VFib, flushing, palpitations, or anxiety. This is pretty much going to stop their heart for the half-life of this drug. Dose: 6 milligrams rapid IV push, followed by 10 to 20 cc's of normal saline. This may be repeated twice, and 12 milligrams rapid IV push. Maximum dose of 30 milligrams total. This drug is going to have a half-life of about 15 to 30 seconds max. As soon as it enters into the body and hits the blood, it is going to start deteriorating. Special considerations: monitor heart rate and cardiac rhythm closely. Warn patient of side effects, which includes dizziness and loss of consciousness. Effects potentiated by carbamazepine or Tegretol and dipridamol use. Theophylline lessens the effect. So if they're taking theophylline for asthma and you use adenosine on them, you might not get as much bang for your buck as you was thinking. Magnesium sulfate or Epsom salt. Classification: gastrointestinal agent, it's a laxative, electrolyte replacement, and anticonvulsant. Action: decreases motor end plate sensitivity to acetylcholine, decreases excitability of motor neuron terminals, relaxes smooth muscle, and this is because it kind of displaces calcium at those junctions, or the initiation of at that motor end plate. Indications: we're going to use it for VTAC, and more specifically, a specific type of VTAC, polymorphic VTAC or torsades. Preterm labor, and this is going to reduce smooth muscle contractions to kind of slow down. Bronchospasm, we can use this in status asthmaticus. Contraindications: any type of heart block, renal disease of any sort, toxemia of pregnancy if delivery is imminent. If the delivery is going to take place, then we'll need to allow the delivery to take place. Side effects on this: we can get hypotension, tachycardia, respiratory depression, maternal and neonatal flushing. As far as that respiratory depression, that's on both mom and kiddo. Flushing can occur from dilation of vessels, CNS depression, and then diaphoresis. Dose on the adult: 1 to 2 grams diluted in about 100 to 250 mils of D5W and administered over 10 minutes. In the pediatric patient, 25 to 50 milligrams per kilogram IV or IM. Special considerations: administer slowly, monitor the heart rate and cardiac rhythm closely, have calcium glucipatate or calcium gluconate available as an antidote if the overdose occurs. So if you overdose somebody on magnesium, calcium is going to be the cure for it. In a pinch, you can use calcium chloride, but calcium gluconate is probably the most preferred choice. Diltiazem or cardiazem, Classifications: cardiovascular agent or calcium channel blocker. Also can be used as an antihypertensive agent. Actions: blocks the calcium channel, slows velocity through the SA and the AV node, and decreases myocardial contractility. Also, the tunica media are smooth muscle in the vessels, and they initiate off of a calcium response as well, and decreases peripheral vascular resistance by relaxing or blocking the calcium channels in the smooth muscle. Indications: atrial fibrillation or atrial flutter, and very simply, whenever we look at the heart, sometimes we can't control the atrial fibrillation, but we can control the AV node, which initiates its contractions from an initiation of calcium. So calcium initiates AV nodal conduction, which conducts it through the rest of the heart and to the Purkinje fibers. So if we cannot control the atria and the fibrillation, and we have an SVT scenario, the drug of choice is probably going to be a calcium channel blocker, which will retard the AV node and slow down conduction velocity. Contraindications: hypotension, bradycardia, any type of AV block, or known hypersensitivity to the drug. Side effects: hypotension, bradycardia, heart block, or congestive heart failure can occur. Dose on this is going to be 0.25 milligrams per kilogram IV over 2 minutes. Most hospitals put a cap on a 20 milligram delivery. So even though you have a patient that's 100 kilograms and his actual dosing would be 25 milligrams, most places will put a cap on the Diltiazem that you can only give 20 milligrams maximum at a time of calcium channel blocker. Repeat at 0.35 milligrams per kilogram IV push over 2 minutes. Now, you can take this up pretty good, but remember, the half-life on this is about 2 hours. So if you get them outside of the threshold, you're going to have all kinds of problems for 2 hours. Maintenance fusion should be at 15 milligrams per minute. Special considerations: do not administer with IV beta blockers. If we block the velocity or the ability to contract, and we slow down the rate as well, we can actually have pretty dire effects. Monitor vital signs, cardiac rhythms, and blood pressure. Not recommended for infusion over 24 hours. This is only being used in the acute phase. Propanolol hydrochloride or Inderol. Classification on this is going to be a beta-adrenergic antagonist, an antihypertensive agent, and an arrhythmic class 2. It's a class 2 antidysrhythmic, which means any class 2s are beta blockers, which is the beta receptor site. Action: blocks beta 1 and beta 2 adrenergic receptors, stabilizes the myocardial membrane, and suppresses ectopic foci. Indications: ventricular dysrhythmias, SVTs, prolonged QT syndrome. Contraindications: because it blocks the beta 2 receptor, asthma or any kind of COPD is going to be a contraindication. Obviously, if they have bradycardia, we aren't going to want to slow it down even more. Hypotension or acute congestive heart failure. Side effects: hypotension, bradycardia, AV heart blocks, bronchospasm, decreased myocardial contractility, and congestive heart failure. The adult dose of Inderol is going to be 1 to 3 milligrams slow IV push. If no response, you can repeat this in 2 minutes, then administer every 4 hours as needed. Pediatric dosing is 0.01 milligrams per kilogram slow IV push to a maximum dose of 1 milligram, and repeat once if needed. Special considerations: administer no faster than 1 milligram a minute. It will potentiate all of your side effects if you do. Use cautiously in patient with lung disease or any kind of reactive airway disease. This brings us to the end of part 3. Again, if you have any questions, feel free to contact me. My name is Roy Smith, roy.smith@redlandscc.edu or smithr@emsa.net. Thank you.